Hi everybody, welcome back to Probably Nothing. This is Series 7, Episode 3. How we've got to almost the end of 7 series already, I do not know, but then again it has been over 2 years. How time flies, I'm sure you understand. Welcome to everybody. If you're joining live, come in. I'm in a dark room. I'm not a weird floating head. Well, I might look like it to you, but it's because the walls are dark behind me. Come in if you're watching live. And if you're not watching live, thanks for watching this in your own time. All of the episodes, Probably Nothing, are always put up on our social media channels and website after the episode is aired. So whenever you're watching this, thanks so much for joining us. My name is Karen and I work for the Eve Appeal. No surprise there. The Eve Appeal is the UK's leading gynae cancer research charity. But I'm sure, again, that's not a surprise to you if you're tuning in, because you must be following us in some capacity or be interested in what we're going to talk about today. So part of the sort of Eve Appeal world is that we run a wonderful and free expert information service called Ask Eve. Now, Ask Eve often get messages from people saying, oh, sorry to bother you, it's probably nothing, but, and then they go on to explain or share their gynae health concern. And in June 2020, we started Probably Nothing because we wanted to kind of not stop people saying, oh, I'm sorry to bother you, but to share lots of information in an accessible way for people, because for most people, yes, the probably nothing is probably nothing. For example, all of the symptoms of all of the gynae cancers are much more likely to be something less serious than cancer. But for some people every day in the UK, that probably nothing is something. So we wanted to highlight different topics, have different themes each series. And when I interview an expert or a guest or a patient perspective regarding the subject, we want to put out the conversation in a kind of easy to understand, informative way where you can ask your questions to us and get the answers and information you need. So, and I always say to the wonderful disruptive media who do all of this for free for us, they'll be rolling their eyes backstage going, she's done it again, that I'll do a really quick intro. And I just don't do a quick intro. So, right, let's get to it. So series 7 of Probably Nothing is all about the menopause, whether that's the signs and symptoms to look out for once you've gone through the menopause. So all of the gynae cancers apart from cervical, so womb, ovarian, vulval and vaginal, are more common, more prevalent in people who have gone through the menopause. Last week, I spoke to lovely nurse Tracy about managing an early menopause, so menopause caused by treatment for gynae cancer. And this episode, we're going to be talking about fertility options for people that have gone through an early menopause as a result of gynae cancer treatment. And I think it's a really important subject because despite how horrific a cancer diagnosis and cancer treatment is to go through, on top of that, if you are still in your fertile years, I'm not really sure if I like that phrase or not, but if you're still in your fertile years and you lose that fertility at an age much younger than you expected, you're having to cope with the cancer diagnosis, the fear, the exhaustion, the stress, the upset around the treatment for that disease, but also having to deal with the loss of a fertility and potentially not being able to have your own biological family in the future. And there's a lot to cope with surrounding that as well. But we're going to be talking about the fertility options. So what is possible, what can be done. So now I'd like to bring in my guest, who should hopefully appear on the screen. We've got Dr. Vikram Talaulikar, who is a specialist in reproductive medicine at UCLH. Hi, Vikram.
Hi, Karen. Thanks for having me on the show. Thank you.
Thanks for joining us. We're really excited to have you. Before we get into the kind of main discussion, can I just ask you to say a little bit about yourself and your work, if that's okay?
Yes. So I'm an associate specialist in reproductive medicine. I work at UCLH Hospital, which is my main NHS-based hospital. I do a bit of private work at 10 Harley Street, which is for the Menopause Clinic London. And my work mainly involves seeing women who've gone through menopause, whether it's natural menopause after 50 or women who have menopause early in their life because of either surgical, medical treatments, or even otherwise premature ovarian insufficiency because of other reasons that can cause premature menopause. So that's in a nutshell why I'm here today to discuss about the topic.
Thank you. And so just thinking about kind of menopause, infertility and early menopause, if someone is under the age of a natural menopause, so say 30s and 40s, and they have a gynecological cancer, and that means, and we discussed lots of the kind of treatments for those diseases last week. So if someone goes through a surgical or chemical menopause because of these gynae cancers at a younger age, does this automatically mean she can't have a baby? Or is it a lot more nuanced than that?
Yes, the second bit is right. It does not automatically mean that you can't have a baby or you can't have any fertility options. We know that fertility is affected by gynecological cancer treatment. And as you've discussed, there are three main parts of treatment that can affect fertility. You have the surgery that may involve removal of ovaries, removal of uterus tubes.
Mm-hmm.
You've got chemotherapy, which can, of course, damage the eggs because of the toxic nature of the medications. And you've got radiotherapy or radiation, which can again damage the ovaries as well as the uterus and its lining. And all three mean that they will compromise fertility. But it's not 100%. Depending on the age, the diagnosis, the type of tumor, the age of the patient, circumstances around how far the disease is spread, there are women who will go on to achieve pregnancy or will have some options before or after the treatment of the malignancy where they could consider fertility.
Okay, so let's kind of go through some of the different options. So, for example, say somebody is diagnosed with a gynae cancer at an early stage, which we would hope for, but isn't always the case. Is there sometimes, depending on the type of disease, is there sometimes time before any treatment starts to kind of get some eggs out and freeze them? Is that common?
It's not common, especially because it's in the recent times that women are thinking about fertility associated with cancer diagnosis.
Mhm.
Traditionally, the cancer treatment, of course, took over the entire care, and
Yeah.
it should be the case. Of course, the primary treatment should focus on cancer, making sure that the woman is cured of cancer,
Mhm.
and fertility does come next. But as we are getting better at treating cancer, we know that many of the women will be cured. It's about late effects now. What's their
Mhm.
quality of life? Will they be able to have children after they've been cured of the cancer?
Mhm.
So, to put your example into sort of spotlight, if someone has had a diagnosis of early stage cancer, and you can divide this between, say, cervical cancer or ovarian cancer or uterine cancer, it will largely depend on what stage the cancer is and what the expectations are for the woman.
Mm.
Would she like to consider fertility as an option after the treatment?
Mhm.
That will be taken into consideration when offering fertility preservation options.
Mhm.
Now, there
Mhm.
are a number of options here. As you rightly pointed out, one of them could be if we have time, if it's an early stage cancer, we're not rushing about to treat the cancer with chemo or any other surgery or therapy. And one of the options will be either creating embryos or creating eggs by stimulating the ovaries and then taking them out of the body and storing them in the freezer, which we often call as oocyte or embryo cryopreservation. But that
And
is
how
critically
long would
dependent
that
on the
take?
time.
Sorry, Vikram. Sorry, how long would that take, for example, if someone had the time to do, or does it purely depend on sort of how advanced the cancer is? So if you've got time, that will be an option. And if that
That's right.
is an option, how long does that process take, the
Yeah.
cryotherapy?
So the process takes about 2 to 3 weeks. So what
Okay.
we often do is we speak with the oncologist to say, are you happy for us to take the next 2 to 3 weeks before this patient goes ahead with surgery, chemo, radiotherapy? The oncologist will often look at the stage, look at the type of tumor, look at the patient's general condition and say, okay, let's go ahead and store some eggs or embryos. And then the process is really, to put it in a sort of easy summary, we often give injections of hormones, we stimulate the ovaries, that causes the eggs in the ovaries to grow, and the aim is to collect somewhere between 10 to 20 eggs which grow in the ovaries. Then, after 2 weeks of injections and scans, we often get the patient to theaters for a minor procedure, collect the eggs, then they're stored in the laboratory. The patient recovers within a week's time, and off you start with the cancer treatment.
Okay. And say that is, we'll go through the different options. Say that is the option pathway we're going down, that someone does that. This is probably an annoying question, but is that is it likely that if somebody has that process that they will end up with one of the eggs kind of fertilizing later and then having a surrogate? Is it likely that that will result in a baby, or is that kind of quite a risky process, or is it kind of, oh no, if we can do it we will, and it's a thumbs up?
Yes, so the risks associated with the procedures need to be balanced against the delay in treatment. For example, when you stimulate somebody's ovaries, there will be increase in hormones, and one of the hormones that often increases is estrogen. Now, we know that most gynecological cancers can have some link to hormones. They can worsen with estrogen. So we're balancing those effects to see, can we control the rise in estrogen hormone? Is it safe for the patient in that case to have stimulation? If yes, then can we actually block the hormone estrogen by giving something called letrozole so that the effects are minimal? Also, the removal of eggs is a procedure where you have to put a needle through the vagina or the tummy to remove the eggs. Again, you have to assess the safety of that procedure, the anesthetic, the bleeding that may happen alongside the cancer diagnosis. Risk associated with procedure, but of course, if you balance the risk and the woman's intentions are that she should preserve fertility strongly, you've had counseling with her, you've had a direct involvement of the oncology team, we then are able to offer the treatment, take the eggs out. You can either freeze them as they are for future use, because they could be fertilized in future. And usually, if the woman can use it either for, say, egg donation in future using her own womb, or for surrogacy, then they could be used in future at any point. The one small caveat I might just say is that sometimes these treatments may not be routinely funded through NHS. So one has to be careful.
Ask, how does that happen? Yeah.
Yeah. So the sad part is that the funding arrangements across the country in the UK or in other parts of the world are different. And so, of course, many women will not get funding through NHS, depending on where they live or what the criteria are, depending on the area where they are having the treatment. Surrogacy, for example, is absolutely not funded through the NHS and often needs the woman to approach non-profit organizations to find a surrogate. So that has to be again balanced when we are making decisions. Who can be invited for egg freezing, and is this feasible, or will it be funded by the CCG for the NHS?
So it's not automatically guaranteed that if you're at Hospital A, NHS Hospital A, you've got an early cervical cancer, it doesn't automatically mean that you will get the whole process we've just spoken about as part of your cancer package. It would mean talking to your team about what's available for you. Yeah. So
that's absolutely right.
We're talking about what can be available, but what isn't always guaranteed for everybody.
Yes.
Okay. So we've spoken about the egg freezing side of things. So say someone is diagnosed with a gynae cancer, they are younger than menopausal age, so they're still having periods and stuff, and they would like to have children in the future, but there isn't time to freeze the eggs because of whatever stage or whatever type of the gynae cancer they've got, and it's like we have to act now on treatment, but person A would like to have a chance at preserving fertility in some form. Is that kind of like, well, if we can't freeze the eggs, that's that?
Well, yes, you're right there. Then we move on to the next stage. Can we do something with their treatment? For example, the type of surgery they will have, the kind of chemo they will have, the kind of radiation they may need to try and optimize it so they have minimal impact on the reproductive organs. So to give you an example of each, if it's surgery, if a woman has very early stage cervical cancer, that's often termed as stage 1, A1, or A2 or B1, then in those sort of early stage cervical cancer, one could opt for something called as a cone biopsy or a trachelectomy, which are conservative surgeries, which try to remove just the part of the cervix that's affected by the tumor, rather than a radical operation where you remove the whole womb. And in those situations, you might say that woman will have a chance to then conceive with her own womb in future. So that's one way of adapting surgery. The same thing can be applied for ovarian cancer. Many young women have ovarian cancers like germ cell tumors or very early stage 1 epithelial tumors, What you can do is offer them conservative surgery, just remove the one affected ovary and the tube on the side of the affected ovary, and leave the other ovary and the womb so that they can be monitored in future, can go on to conceive naturally, or consider IVF or egg freezing after the affected ovary has been removed. That's in terms of the surgical things you can do.
Yeah.
Medically, you can offer somebody GnRH analogs. These are injections which suppress the ovarian function. So a lot of women now who have chemo for gynecological cancers or non-gynecological cancers can be prescribed GnRH analogs, which are injections once a month while somebody completes their chemo. And the whole basis is that the GnRH keeps the ovary inactive, keeps it suppressed. So you may prevent some damage to the ovary that will happen from the chemotherapy. Not all.
It's not guaranteed that if you have the suppression, when the ovary wakes up again after treatment, it's back to normal. It just means there's a chance something can be saved. It's
Absolutely
not a guarantee
right.
it's back to before cancer.
Absolutely right. So again, unrealistic expectations should not be set up, and it's important that some women, a subset of women, may benefit. And there are controversial results. Some people have found that using GnRH does give some benefit to young women. They have some reserve which is saved and go on to establish ovarian function after chemo. Others have found that they've not been particularly useful. So I think we need to understand more who benefits and who doesn't. But yes, it's one of the avenues which can be explored, especially because it doesn't have any major side effects. So you can do it while the woman receives her chemo.
Sure.
Yet another way is transposition of ovaries for radiation. So many women will have radiotherapy as part of their cancer treatment. And if you can take the ovaries out from the pelvis, which is where your radiotherapy will be focused in the pelvis. So if you can take them slightly out and laterally out of the pelvis on the upper side of the tummy, then you could argue that the radiation won't affect the ovaries deep down in the pelvis, and ovarian function can be saved or retained. Again, just like you pointed out, it's not 100% fix, and it's possible that despite the best of surgery, laparoscopic procedure, about 50 to 70% of these procedures are successful, and the ovaries may retain some ovarian activity, hormones, and egg activity. In some other women, about 50%, the procedure may not work, and the ovary may still fail to function after.
That must be very difficult for the 50% that it doesn't, because I can imagine, obviously, like I said at the beginning, it's hard enough going through all of this anyway, and at a younger age, and then the tiny bit of hope that you might have for something. So it's not impossible, but it's not a guaranteed magic wand to.
That's right.
And if you have the ovaries transposed and put to sleep for a bit, and while you're having treatment or surgery in the other areas, so like the womb and cervix, when that's over, the treatment, and the ovaries are woken up, and let's say they were working again, let's say something was saved, great. Does that mean because the womb has been removed, or say there was radiotherapy that affected the womb, that yes, there might be eggs there still, but that the person can't carry a baby? So would they have to then have their eggs sort of plumped up and removed and frozen and or put into another person as surrogate? Is that the way that would work?
That's right. So again, radiation impacts not just the ovaries. And if you've managed to save the ovaries from the worst impact of radiation, there's still egg activity there, then the aim will be to harvest the eggs from the ovaries once they are functional. Now, there are pregnancies reported in women after radiotherapy. So it's not a complete no-no, but it's uncommon. It depends on how much of the damage has happened to the womb lining because of the radiation in the pelvis. So women who do attempt pregnancies after very high dose radiotherapy, one, may not achieve pregnancy and may need surrogacy, but also have a higher risk. For example, because the lining of the womb may struggle to develop, could go on to miscarry, have early preterm birth, or sometimes have problems with the growth of the baby. And so for those reasons, if they cannot make use of their womb, or the womb doesn't respond to the pregnancy hormones, then of course they will be able to save those eggs or embryos for use for surrogacy. Again, the most important thing to remember is if it's embryo or egg storage for the purpose of surrogacy, funding through NHS becomes a problem. and you may have to consider self-funded cycles to have the embryo or egg freezing in that circumstance.
And so it's there are kind of the two strands there, where if you have your ovaries that are still working after treatment but no womb, then it would be the surrogacy option if you're able to. We understand not everybody can or can afford to. And then if you have no ovaries due to treatment, but your womb is left intact inside you, then it's about egg donation for you to carry a baby, but not your own egg, somebody else's egg.
That's right.
Is the surrogacy route, you said, is not always funded and people might have to self-fund. Is that the same for egg donation, or are there people that just want to give their eggs to people and you can just go online and order a packet of eggs?
Well, again, egg donation IVF is not routinely funded throughout the country. There are different CCG guidelines regarding funding of egg donation IVF. And also, of course, in cancer women, it's a little bit different. You have to consider what treatment they have had, how safe it is for them to conceive using egg donation. And so if you're considering egg donation IVF for a cancer survivor, then of course, yes, you will apply to their CCG for funding specifically in their case to say, can the NHS fund? And of course, the application depends on certain criteria, but some women will be funded, others may not, depending on what criteria are being used. But yes, it's one of the options that is available. Women have interest and can do egg donation IVF.
And is egg donation and is surrogacy, you're talking about potentially having to self-fund if it's not covered wherever you live and whatever team you're being looked after by the NHS. $1 million question, maybe literally the $1 million question. Is it expensive?
Yes, any fertility treatment is expensive,
How
especially
expensive are we talking, Vikram?
if you look at surrogacy and you go through a non-profit organization. Often the surrogate and the couple who want to have the child through the surrogate will often have an agreement in place. And of course, there is no direct exchange of money because third parties shouldn't be involved in matching, for example. But generally, the costs of surrogacy can vary anywhere between 10,000 to 20,000 pounds. That is to cover the cost of pregnancy for the surrogate. If you're looking at egg donation IVF, provided that all the medical conditions are met and it's fit enough and fine for the woman to go through egg donation, and she can use either her own family or friends or a donor bank egg, in which case usually you're looking at costs between 5 to 10,000 pounds for egg donation IVF. Now these are rough costs in terms of every clinic will be different, every medical situation will be different, but that gives you an idea of what you're looking at.
Sure. And how much, we always talk about whether it's with regards to cancer or not, but society talks so much about, a woman's fertility and how it decreases over time, and 35 there's a drop-off point, all of that stuff. Does age come into play very much when it comes to sort of freezing eggs? If you're say 37 and you could cancer-wise freeze your eggs, would your team be less likely to encourage you to because you're not 25?
I think you're absolutely right. Age is the single most important factor when you're looking at either saving fertility or fertility treatment using one's own eggs. And of course, if you have a very young person, then they will have much more distress from loss of fertility, but their ovarian reserve or egg count is likely to be much better, and they will respond to fertility preservation better. If the same situation, same kind of cancer at the same stage happens in a woman who is past 35, then your balance of risk versus benefit will tilt, because of course the benefits of then going through a fertility preserving treatment may not be as good as somebody who is 25, for example. Now, again, important to remember that you cannot generalize rules, because everybody's tumor stage, everybody's clinical condition is very specific, and so therefore you cannot generalize advice. And then it's individually choosing women who can be benefited and who cannot benefit from the fertility preservation.
Of course. Thank you. So we've got a few minutes left. So am I okay to just blast through? We've got 7 questions that have come in. So I'm just going to go for it. Right. Okay. How easy is it to find a surrogate in the UK?
It's not very easy. It can be a challenging process, especially because it's legal to have surrogacy in the UK, but many of the aspects are not legally enforceable. And you often have to have a parental order after the birth of the baby. And remember that it can take a few months. If you're lucky, you get a surrogate who is willing to do this for you and matches your criteria, then it can happen in months, but it could take a few years or a couple of years sometimes to find the right surrogate. So it's variable.
I've had complex atypical hyperplasia and been told to avoid estrogen. What are my options?
Yes, atypical hyperplasia of the endometrium is estrogen dependent. The first thing to say is you should have been treated for it. So you would have had lots of progesterone, which is the treatment for hyperplasia. You would have had repeat biopsies to make sure that the hyperplasia has disappeared. Thereafter, if you did decide to go ahead with any form of hormone replacement therapy, then that would be combination of estrogen with progesterone all the time continuously to make sure that it suppresses any womb lining thickening or hyperplasia in future.
Okay. Fertility after having stage 2 precancerous cells removed from the cervix. Are you a lot less fertile if you've had SIN2 removed?
Well, no. Again, if you've had a superficial removal of cells as part of your colposcopy and cervical abnormal cell removal, we know that more or less pregnancy outcomes are pretty good in terms of the background population. It's only if you have a deep surgery on the cervix, remove a lot of tissue, deep cone biopsy, then there's a small increase in the risk of preterm labor. But for women who have CIN and a normal colposcopy, less than 10 millimeters of the cervix removal, there shouldn't be much risk in terms of obstetric outcomes.
Okay. Can women still with a womb, okay, so can women with a womb receive an egg donation via the NHS or just privately? So no ovaries, just a womb left.
Well, yes, we talked about this. So there are different arrangements as per CCGs. It slightly depends on what diagnosis was it for which you had the ovarian removal, and then of course your medical background. So all that has to be considered: smoking, BMI, etc., etc., and then they make a application for funding. Some CCGs will fund egg donation IVF, others may not be able to do so. So explore with your own GP and your CCG before you decide for self-funded treatment.
Sure. Not just privately, that's good to know. I've been waiting 9 months for my fertility clinic appointment, a hysterectomy post-womb cancer, and there's no sign of getting an appointment soon. I'm now in my 30s. Will a year waiting for egg removal make a difference to potential success of IVF and surrogacy?
Well, if you haven't had chemotherapy or radiotherapy and it is just the surgical treatment, then it shouldn't impact your ovarian store of eggs, what we call as egg reserve. So waiting for another 6 months or a year should not technically impact the number of eggs you carry. I'm sorry that you've had to wait so long. Ideally, nobody should be having to wait that long for a fertility opinion. But hopefully, I hope you get there within the next 6 months. It shouldn't make a huge difference. Fingers crossed.
Currently under oncology for prevention, but I'm also trying to conceive. What can I do? I'm not sure what they mean by prevention. So it might have been cervical cells removed. It might be BRCA or Lynch, and maybe thinking about gynae surgery to remove those organs. So someone's under oncology for prevention in some capacity. They're trying to get pregnant.
Okay. I think prevention probably means risk-reducing surgery. That looks the most likely. So if you're BRCA and you're having risk-reducing surgery, ovarian removal, then yes, I think many women now choose ovarian store eggs, going stimulation eggs. If you've not started or completed your family, then at the moment it looks like that doesn't impact any majorly in terms of your risk of breast cancer or ovarian cancer. So that would be one option before you go through the operation.
Would you advise people that have the BRCA alteration and are on their sort of journey to having their ovaries removed as preventative measures? Do you get people kind of saying to you, oh, should I just have a baby quickly and then have my ovaries removed afterwards? Like, can people sort of afford to wait a little bit if they find out they've got the alteration?
Of course, remember, medically we can only advise, and so 40 is often considered as it doesn't mean that at 40 you must get your ovaries removed.
Sure.
It's always weighing the balance of what's the risk in terms of waiting longer. If you're planning pregnancy the next year after 40, then just finish it off, and then once your childbearing is complete, go ahead with the operation. It's not a strict rule in that case.
Not as clear cut as by 40, yes or no? Okay. And the last question, I only have half of my cervix left now. How will it be affected throughout pregnancy? Or is pregnancy affected, I guess, by having half a cervix?
Yes. So half a cervix, it looks like you've had a deep cone biopsy or a removal of a lot of tissue to get rid of the cancer cells. The only major impact of this will be how the cervix holds during pregnancy. So we know that your risk can double up if you've got a major tissue removed from the cervix. So it's really critical that if you get a positive pregnancy test, you let your health team know you're being surveilled, having quite a bit of surveillance through scans repeatedly in your early pregnancy, and they watch the length of the cervix and how the cervix holds during pregnancy to try and avoid, if possible, chance of early labor or preterm labor. So that's critical.
With these pregnancies where someone's had a bit of their cervix removed, is there a sort of point in the pregnancy where the parent and the medical team can breathe a sigh of relief, like we've got past this point, it's going to be okay? Or is the sort of risk, the slightly increased risk of an early a premature birth or preterm labor, is that kind of a concern the whole way through?
Well, in a way, not whole way through. I would say that with the current improvement in survival of babies, we often say that if someone has gone past 30, 32 weeks gestation, then it's much, much more relaxing. If someone comes below that 28 weeks, okay, and then below that becomes a bit of a sort of worry for us. And so again, once you get to, I think, 32 weeks plus, most obstetricians, pediatricians will be happy. We don't want that in the first place. We want the pregnancy to carry on as long as possible beyond 36, 37 weeks. But I think below 32 weeks, then one starts getting worried, certainly below 28 weeks.
Okay, thank you. So just to wrap up, because we've only gone 3 minutes over, which is a good record for me. Sometimes you're lucky, Vikram. I've let you do all the talking this time because I've got a lot less that I know about this time. So just before we wrap up, if someone's watching this and whatever version of what we've spoken about applies to them, depending on what type of treatment they've had or having, can you just kind of, if you know, kind of a few places where people could be signposted to next to kind of explore what their next options are? Just so we've got something for people to go away with.
Yes. So I think the best websites or places would be one, HFEA, which is Human Fertilization Embryology Authority.
HFEA, yeah.
That gives you lots of information about donor egg treatments and how women are choosing different forms of treatment, what clinics offer in the UK. You've got the other one, which is the British Fertility Society, BFS. It's got lots of patient information leaflets and information for carers and health professionals as well. So that's very useful portal. You have got non-profit organization. The one that I've usually commonly worked with or heard about is Surrogacy UK. And there are other couple of organizations which also offer surrogacy services. Those will be very useful. So I think those three are the key. But there are a few others, but I think those three will then signpost you to other
resources. Starting point. Great. Thank you so much, Vikram, for that chat. I think that was really amazing. It was really, really interesting, and it was so great to get people's questions answered. Thank you. You go and wait in the green room, and I'll say goodbye to you in a second.
Thank you so much. Thank you
so much. Thank you. Bye. How fascinating was that? I could have asked Vikram another million questions, and I'm really glad that you lovely lot sent your questions in beforehand, because getting the questions I know that people are watching really want answered is it feels like a big tick off the list. And I hope that conversation with Dr. Vikram Talaulikar wasn't too upsetting for people. Fertility is a really delicate subject, isn't it? So I hope it wasn't, I hope it was helpful, even if it was distressing. I hope it was kind of helpful and informative, and kind of gives people a bit of perspective and options of what might be possible if you've gone through any of the treatments for gynae cancer and early menopause as a result. So again, if you're watching live, thanks for watching live. If you're watching on catch up, thanks for watching on catch up. We adore you all, whoever joins in. We wouldn't be doing these series if people weren't watching them and finding them helpful, so thank you so much. I'll be back next week, the 25th of October, for our last episode in series 7, and I'll be speaking to 2 people that have either gone through menopause as a result of gynae cancer treatment or had a gynae cancer after the menopause, and speaking about their personal experiences. If you've got any questions about gynae cancer, any gynae cancer concerns, please do email the Ask Eve helpline on nurse at eveappeal.org.uk. Thanks for watching and see you soon.